Hello, it's Mark Kris from Memorial Sloan Kettering. And I'm speaking today about the ever-rising prominence of neoadjuvant therapy for patients with locally advanced lung cancers. There is more and more data emerging that the neoadjuvant strategy is a better one. Many of you saw the press release from Merck that their randomized trial comparing chemo to chemo plus pembrolizumab in the neoadjuvant setting led to improved event-free survival and also improved pathologic complete response rate. This comes in addition to the data from the AstraZeneca trial with durvalumab, saying they've already achieved their endpoint of higher path CR rate versus chemotherapy alone, and also the data with nivolumab from Bristol-Myers, saying that nivolumab plus chemo leads to a better event-free survival, a better path CR rate, and that information has led to FDA approval for their regimen. So we're running the table with this very, very positive data. And I think it's just a sign that the approach is safe and approach is effective. So a huge question that's come up, and I just came from a meeting of lung cancer experts, say, well, what do you do? If you have a patient with a small tumor, a 3-centimeter tumor, do you recommend immediate surgery followed by adjuvant therapy, chemo, and then a checkpoint inhibitor if appropriate, or do you proceed with neoadjuvant therapy if appropriate? And the truth is, it's a very, very difficult decision. We have overwhelming data that the neoadjuvant approach works for that patient. And please remember, this is a clinically staged patient. This is not the patient after their surgery, where I think we have very clear path here. We have adjuvant data and adjuvant trials for those patients. But for the patient that's in your office with a small tumor, or a small tumor and only hilar lymphadenopathy, the decision there isn't data-driven. It is experience-driven. And the data that's out there right now is that neoadjuvant therapy is a better way to go. And why is that? Well, I think the first reason to me is that it is probably a better regimen. I think many of you saw the recent clinical trial by Patel et al. In the New England Journal of Medicine with melanoma. It was an interesting trial. They gave a checkpoint inhibitor for 18 doses after surgery for melanoma versus 3 doses of checkpoint inhibitor, surgery, and then 15 doses of the checkpoint inhibitor. So it was 18 doses versus 18 doses. The only difference was the 3 before surgery. And lo and behold, the 3 before surgery led to a better event-free survival. There's data preclinically in lung cancer that the same thing is true. Tina Cascone has published on that very years ago. So we could talk about why, but it appears that neoadjuvant is just better. There's other advantages to it as well. I think a big one is that all the information shows that it's better tolerated. You're more likely to give all the drug. If the drug isn't working, you can see that and you can stop the drug. Also, the drug is causing a side effect. You can see if it's working or not and use that decision to stop. It's different than when you're giving in the adjuvant setting where you don't really know if the drug is working or not. So I think that it's a time to change some of our standards. I think when patients appear with lung cancers, other than the teeniest tiny ones that might be detected through screening, you need to convene your multidisciplinary group. You need to weigh the pros and cons of immediate surgery versus neoadjuvant therapy and surgery. And I think in those situations that it makes the most sense to give neoadjuvant therapy. There is emerging data, more data coming in. It's already a FDA-approved regimen with nivolumab and chemotherapy, and I think we're moving to making that our standard of care now. So I think the way to handle it today, though, convene your multidisciplinary panel about every patient, other than those with the tiniest of lung cancers, and put your heads together to see what the best treatment is for that patient.